Hi, my name is Megan Rulifson, and I'm going to talk about the comorbidity of COPD and dysphagia. So first, I'm going to cover what is COPD. It stands for chronic obstructive pulmonary disease, and it's an umbrella term that kind of talks about a lot of different illnesses that cause issues with the lungs. So emphysema, chronic bronchitis, and asthma are the most common things. The most common cause is cigarette smoke. So it's usually people that have smoked for several years that end up with COPD. Some of the symptoms include shortness of breath, chronic obstructive cough, loss of appetite or weight loss, and fatigue. And typically patients with COPD have between 1 to 2 exacerbations each year, and I'm going to talk about that a little bit later in the presentation. So these are the topics that I want to cover: coordination of breathing and swallowing, sensory reduction, exacerbations, and decreased muscle strength. So the first thing is coordination of breathing and swallowing, and how this kind of differs for people that have COPD versus a normal swallow. The normal swallowing occurs between or during the beginning or the middle of an exhalation. So that way we're not inhaling any of the food or drinks that we're eating or drinking. And swallowing with someone who has COPD occurs during an inhalation. So this greatly increases the risk of oropharyngeal dysphagia. And there's also an increased duration during the pharyngeal phase. So all that food and drink is sitting there for a longer amount of time than with a normal swallow. And this visual over here to the right shows what a normal breathing pattern looks like. So whenever it's coming out during that exhalation rather than that inhalation, or when we're swallowing during the exhalation rather than the inhalation. The next topic I'm going to cover is a sensory reduction. Patients with COPD have reduced sensations, which causes a delayed swallow. So the oral pharyngeal sensations are especially reduced, which causes the pharyngeal swallow to not be triggered until the bolus is already in the pharynx. So, this sensory reduction can cause more residue, and aspiration risk is a lot higher with the increased residue in that delayed swallow. So that kind of relates back to what we just talked about with the timing. And exacerbations, like I mentioned earlier, these are also called flare-ups. So it's basically just worsened symptoms of COPD or new symptoms of COPD. A lot of times patients will have to be hospitalized for these as well. So a lot of doctors really just try and work on decreasing the risk of these. And some of the most common causes of exacerbations are viral or bacterial infections of the lungs or other types of illnesses. So in exacerbations and dysphagia kind of both work against each other. So if the patient has dysphagia, they're more likely to have exacerbations. And if they have a lot of exacerbations, their dysphagia is also worse. And over here to the right, I've got just a visual that shows kind of warning signs of when exacerbation is going to happen for patients. So these patients with dysphagia tend to have increased exacerbations. So if they don't have a normal swallow, studies show that patients who did not have a normal swallow reflex had more exacerbations. And dysphagia complications include aspiration pneumonia, dehydration, and airway obstruction, which cause an increase in exacerbations. So they kind of, like I mentioned, work against each other. And 88% of patients who had a recent exacerbation also exhibited delayed swallowing initiation. And the next topic is the decreased muscle strength. So patients with COPD tend to have that decreased muscle strength. And over here on the left, you'll kind of see why. A lot of times once they develop COPD, then they feel breathless. And then whenever it makes them fearful when they engage in like physical activities because their breathing is not working properly. So they tend to avoid these activities. And then they do less of these activities, which causes their muscles to become weaker. So this is the same thing for muscles involved in swallowing. So these muscles also have that decreased strength, including muscles of the tongue and all the muscles used in swallowing as well. And we see this through the delayed initiation of the swallow. of the pharyngeal swallow and decreased bolus preparation. So that tongue isn't moving that bolus back and forth and preparing it for the rest of the swallow pattern. And just to kind of review all of the topics we've gone over, we went over the coordination of breathing and swallowing. So we know that swallowing with COPD occurs during an inhalation rather than an exhalation, like with a normal swallow. There's a sensory reduction with patients with COPD. So there's higher residue and the pharyngeal swallow is delayed. There's increased exacerbations with dysphagia patients. The more exacerbations, the worse the dysphagia, and the worse the dysphagia, the more exacerbations. And there's also that decreased muscle strength. So there's a decreased strength to initiate the pharyngeal swallow and to manipulate the bolus. Okay, and these are all of the resources that I used. Thank you.